Good day, this is Elizabeth from New South Wales Health. This presentation tells the story of a population-wide data linkage to reduce premature mortality in New South Wales residents who have been in contact with mental health services. I'll be presenting the results from a retrospective observational cohort study examining cancer incidence in New South Wales residents who have been in contact with mental health services. I'll walk you through the background and aims of the study before describing the methods and presenting and discussing the results. Excess mortality in people with mental health conditions is a major public health problem. People with serious mental health conditions have standardized mortality rates at least double that of the general population, leading to a 10 to 15-year reduction in life expectancy. Cancer deaths are a major contributor to excess mortality in people with mental health conditions. Some cancers occur more often in people with mental health conditions because of increased risk factors. However, most excess cancer mortality in people with mental health conditions arises from increased cancer mortality rates due to health care-related factors. The New South Wales Mental Health Living Longer program establishes a population-wide data linkage using routinely collected data to build New South Wales Health's capacity to understand and prevent excess mortality in mental health service users. Cancer care and mortality is one of the program's 4 themes. Each theme involves a staged approach, including quantification of the scale of the problem in New South Wales, identification of personal and clinical predictors, examination of variation in care, identification of opportunities for policy action, service change or intervention, and the monitoring of changes over time. So this presentation focuses on the quantification of cancer incidence. We address the research question, do New South Wales residents who have been in contact with community mental health services have a higher incidence of cancers than other New South Wales residents? Studies in other states and countries have found that cancer incidence in people with mental health conditions was no greater and sometimes lower than that of the general population, yet cancer mortality rates were higher. Most of these studies focused on specific mental health subgroups, such as people diagnosed with psychosis or depression. This study is unique as it examines cancer incidence in all New South Wales residents who have been in contact with mental health services. So moving on to the methods, first I'll describe our data sources. We used linked data from the datasets pictured here in the slides, the New South Wales Mental Health Ambulatory Data Collection, the New South Wales Cancer Registry, the New South Wales Registry of Births, Deaths and Marriages, and the Cause of Death Unit Record File. And we selected data from the period of the 1st of January 2005 through to the 31st of December 2016. These datasets were linked to a master index file, which summarizes demographic information for all people in New South Wales who have had contact with any in-scope service. And the master index file was constructed from 9 routinely collected datasets. The New South Wales Cancer Registry includes details of new cancer notifications. People with multiple diagnoses of the same cancer over the study period were only counted once. However, different diagnoses were counted as new cases. For example, if a person developed breast cancer and lung cancer over the study period, both of these would be counted towards overall cancer incidence. The New South Wales Mental Health Ambulatory Data Collection includes data from all non-admitted public mental health care, including community mental health services, acute and emergency teams, day programs, outpatients, outreach services, and hospital consultation liaison services. We only selected New South Wales residents who attended the service activity face-to-face or via telephone. So moving on to the analysis, we firstly described characteristics of New South Wales residents diagnosed with any cancer during the study period. We then calculated the crude and age standardized rates per 100,000 persons per year for New South Wales residents who had contact with mental health services and those who did not. Patients who developed cancer over the study period were only classified as mental health service users if their first contact was prior to their cancer diagnosis. 5-year age groups were used up to age 85 years and above to calculate standardized rates for overall cancer incidence. Age restrictions were applied to calculate cancer-specific standardized rates because of small numbers in some age groups, which would have made direct age standardization unstable. So prostate cancer rates were restricted to males aged 30 and over at the start of the study, Melanoma rates were restricted to people aged 15 years or over at the start of the study. Lung cancer rates were restricted to people aged 30 or over at the start of the study. Cervical cancer rates were restricted to people aged 20 to 84 at the start of the study. And breast cancer rates were restricted to females aged 20 and over at the start of the study, noting that breast cancer was considered to be specific to women, although it can occur rarely in males. The New South Wales population in 2001 was used as the reference population in direct age standardisation. Lastly, the directly standardised rate can be interpreted as what the crude rate would have been in the study population if it had the same age distribution as the standard population. So between the 1st of January 2005 and the 31st of December 2016, there were 479,950 new cases of cancer in New South Wales, of which 11,919 occurred in people who had been in contact with mental health services prior to their diagnosis. Patients with cancer who had been in contact with mental health services had a median age of 63 years with an interquartile range of 40 to 86 years. This compares with a median age of 68 years with an interquartile range of 49 to 87 years among patients with cancer who had no contact with mental health services. Overall, 54% of people diagnosed with cancer over the study period were male. This slide shows further characteristics of New South Wales residents who developed cancer over the study period, characterised by whether they had contact with mental health services. We can see that patients with cancer who had been in contact with mental health services had increased odds of living in rural and remote areas or areas of greater socioeconomic disadvantage compared to those who had not been in contact with mental health services. Also, patients with cancer who had been in contact with mental health services had increased odds of being diagnosed with cancer that had grown and spread compared to those who had not been in contact with mental health services. This slide shows cancer-specific incidence rates. The top four most common cancers were prostate, breast, melanoma, and lung cancer. We also calculated the incidence rate for cervical cancer, as it's of interest to our study as we plan on examining participation in cervical cancer screening further down the track. Overall cancer incidence for New South Wales residents who had been in contact with mental health services was lower than for the general population. This was also true for the main cancer sites of prostate, breast, and melanoma. By contrast, incidence was greater for lung cancer and cervical cancer. This study only assessed lifetime contact with mental health services. This means if somebody contacted mental health services once in 2005 and was diagnosed with cancer 10 years later, they would still be classified as a mental health service user. However, it may be of more clinical relevance to examine rates in those who had recent contact with mental health services, for example, contact in the 12 months prior to their cancer diagnosis. The strengths of the study include the use of the master index table, which contains demographic variables for every person in scope for the study. And the variables come from 9 linked data sets, which increases the chance that variables missing in one database may be available in another. And also the New South Wales Health Data Resources for Cancer and Clinical Mental Health Care. They provide a resource which is really unique in Australia. New South Wales Health's cancer and mental health datasets cover services for the whole New South Wales population, and both datasets are already able to be routinely linked through their inclusion in the Centre for Health Record Linkage's master linkage key. Because of this coverage, we can address limitations in previous studies. Because of limited sample size, many previous studies have grouped cancers as a single diagnostic entity rather than investigating different patterns for individual types of cancer. This is important because cancers are a heterogeneous group with diverse patterns of screening and care. We saw this in our results where although overall cancer incidence in people who had been in contact with mental health services was lower than those who hadn't, lung cancer and cervical cancer incidence was higher. This is a similar pattern to previous studies in Queensland, Western Australia, and Canada. And these results show that reducing lung and cervical cancer incidence may require targeted prevention activities and more effective and integrated healthcare. So now that we have established incidence rates, our next step is to examine mortality rates. Previous studies have found that although overall cancer incidence is no higher than the general population, mortality from cancer and people who have had contact with mental health services was higher. We also plan on examining participation in screening services and predictors of stage at diagnosis, as we saw that patients with cancer who had been in contact with mental health services had increased odds of being diagnosed with cancer that had grown and spread compared to the general population. So thank you for taking the time to listen to this presentation. I'd like to acknowledge the support of the following agencies: Cancer Institute in New South Wales and the New South Wales Ministry of Health, of which the Centre for Health Record Linkage is part of.